There are three good reasons for using distal jejunal feeding in the management of patients with severe acute pancreatitis. First of all, patients often have obstruction of the upper GI tract, particularly the antrum and proximal duodenum, due to the proximity of the large inflammatory mass of the pancreas. Secondly, pancreatic rest might well be important, and we know from our physiological studies that you have to feed at least 40 centimeters past the ligament of Treitz before you can provide enteral feeding without stimulating the pancreas. And then thirdly, there's the intriguing possibility, based on experimental data, that activation of the ileal brake through PYY mechanism might in fact suppress the pathophysiological response of acute pancreatitis and allow the disease to resolve. This is a CT image transecting the area of the pancreas in a patient with late necrotizing acute severe pancreatitis. As you can see, the pancreas is now dissolved into a liquid bag, which is causing obstruction of the stomach on the right and the duodenum all the way around the mass. Duodenum. As you can see, there's very little stomach left on the right hand side here. The concern is that secretions might build up here and vomit and increase the aspiration risk. Consequently, you need to decompress as well as try and feed distally. And with our technique of transnasal endoscopy, using a small 5.8 millimeter endoscope, you can actually cannulate through the compressed duodenum around the mass and then down distally, and eventually you get past the ligament of Treitz. It's quite remarkable how you can do this with a small endoscope, but you can do. And you see the lumen opens up. You can then deploy a guide wire into the open bowel below the obstruction, pull the endoscope out, leaving the guide wire in position, and then have a free conduit to pass the feeding tube over the guide wire and into position. This illustrates what we use. It's a double lumen feeding tube system. So first of all, there's a thicker outer tube, which is the gastric tube. And as you can see, it goes in here. It's got perforation so it can decompress the stomach. We prefer to push this actually through the pylorus and into the mid-duodenum, simply because it provides a stent and prevents curling up in the stomach. Having placed it in that position, we then can feed the second tube, which is the smaller J tube, which is only 9 French, through the wider one, which is a 16 French stiffer tube, and then push it over the guide wire. Remember, the guide wire is still here after endoscopy, and we can do this blindly without fluoroscopy, particularly in patients with an ileus with acute pancreatitis. It flows remarkably well down way beyond the obstruction, allowing successful continuous feeding in the jejunum and decompressing proximally. This is important because, from surgical principles, if you've got any obstruction at all, you must decompress proximally and feed distally. If you just feed distally and don't decompress, secretions will build up in the stomach, leading to increased aspiration risk and failure. This shows one of our patients with severe acute pancreatitis, early stage. As you can see, he's got a generalized ileus. We've managed to place the G tube through the stomach, kept it fairly straight. You can see it's resting in the mid part of the duodenum, and then we fed the J tube through over the guide wire, and it goes round and round and round, several loops, and then finally around here. And this is about 80 centimeters past the ligament of Treitz, actually way down in the pelvis, allowing successful feeding and decompression of the proximal stomach. This shows the final placement. Equally important is that we must tether the feeding tube with a bridle. The bridle that we use is shown here. It has a string that goes around the septum on either side and then is clipped into place. Shown here is the gastric decompression. You can see bile refluxing. We always put low continuous suction on for the first 3 days to decompress the stomach proximally, and then see what the level of gastric outlet obstruction is and whether we need to continue with suction. And then secondly, we can feed. We start slowly, always at only 25 cc's per hour, and increase with time. It's important to start slowly because the gut only needs about 25% of requirements to maintain its function in critical illness, and overfeeding in the situation can be dangerous. So always start slowly and increase with tolerance. So today we are demonstrating how to place our NGJ tube, or distal jejunal feeding tube. Basically it's a tube within a tube. One tube is the gastric portion, which is relatively short. It's 37 inches or 97 centimeters in length, but 16 French, and that is the outer tube here. And we can undo this thing here. Right. So that shows the G tube itself. As you can see, it's quite firm and it stays in place. It doesn't tend to curl, don't move it around too much, curl around in the stomach. It has perforations at the end so it can decompress the stomach. And then, as you see, the J tube, which is smaller, only 9 French in diameter, fits nicely through the outer tube and can be passed over the guide wire once it's in position down into the jejunum. So I'll just demonstrate that. It's obviously very important before you start to flush the whole system, and so that it makes it move through the other better. So the introductory position, this little black mark here, has to be within that window, just there, so you can see it, and that keeps it in position. As you can see, in that position you've got the G tube and then the J just coming through the G portion here, and that makes it easy to pass into the patient via the nose, through the stomach into the duodenum. The second thing is that we need is to make sure that we always flush everything, and so you'll be able to demonstrate that. Okay, and we put it all underwater, keep it nice and wet. The other critical thing is the guide wire system. This tube comes with its own guide wire, but I would not recommend using that because it's one of these Cook guide wires and it bends. Rather use one of these ERCP jag wires, a Metro jag wire, which is 4.5 meters long, longer than we usually use. In fact, we could put that all the way down to the colon if we wished. But it's a beautiful flexible end, and it goes round loops of bowel very well, as we will demonstrate during the procedure itself. Again, this has to be flushed before you start. The third vital piece of equipment is the bridle. You have the bridle somewhere? Where's the bridle itself? Okay, so the bridle itself consists of 2 pieces of tubing. Each of them becomes lubricated. You pass one through one nair, one through the other nair, and when they get towards the back of the septum, they click together beautifully like that. And then you can basically hoik it round the septum, and you're left with a cord like that around the septum. And then you can tie it together on the outside of the nose with this little bolster, which is specific for that feeding tube. It's 16 French, and it clips onto the feeding tube like that. We will demonstrate it, and holds everything in position. So those things are absolutely important before you start. Also make sure that all the tube systems flush before you start and flush at the end. Otherwise you'll have a tube that they'll tell you is blocked before you start. So preparation is all important. Okay.
Okay, hang in there. I'm just going to put a little bit of humming jelly in your nose, okay?
Performing the procedure today is Dr. David Lowe, one of our third-year GI fellows. We can usually teach our fellows to do this procedure confidently within 2 to 3 weeks of their nutritional support rotation.
Okay, a little bit on the other side. There we go. Coming it up nice and good.
So keep it as straight as possible, and remember not to aspirate because secretions will block your endoscope. So until you get round and get good views of the vocal cords. That's great. Okay, now go to the right. Okay. Okay. Maybe head to the left a bit, David. So the importance is that we can check out for pathology on the way down. A lot of patients get severe reflux and can cause major problems, so we always inspect carefully. Once we're in the stomach, then we're looking for held secretions. As you can see, there's quite a lot of gastric fluid here that needs to be aspirated and decompressed before we move forward. So we reduce aspiration risk again. We can also identify abnormalities in the extrinsic abnormalities such as compression of the stomach by general inspection. Go in and do a retroflexion and look back at the cardia. Just make sure that everything's cleaned up. It's got a hernia.
Yes.
So there's some superficial ulceration around the prepyloric area. Here we pop through. There's a little bit of antral distortion. It's not too bad. Large folds here, but usually, again, with a small scope, it's pretty easy to squeeze through. And it's usually the first part of duodenum that causes most problem, both because of distortion and bismotility. There we go. See how we pop through? Now it's open. There's the ampulla on the left. Okay. If we collect juice for cytokines, we usually collect it in this situation here. But now we try and get as far as we can down the course of the duodenum and out the other side. And actually it's amazing, if you use fluoroscopy, you actually see the tip of the scope often emerges from the beyond the ligament detritus. You can see there's not much in the way of motility here. Pooling of secretions. Again, a fairly characteristic thing in severe acute pancreatitis. Showing an ileus. It's a pretty classic ileus picture. If you took an X-ray now, you'd see air fluid loops all over the place.
I think this is
That
about
is-
as far as we can
You got the whole scope in?
Yes, sir.
Okay. So sometimes we manipulate up, but this is perfect. So now we pass the guide wire through there, and as you can see, it should be fairly easy to go there blindly as far as we can. That's good. Let it bounce off the side to make sure it doesn't get caught in the house striations. And then sometimes it doubles back on itself. So probe backwards and forwards, David.
There we go.
It should go easy. So just keep moving forward. So keep going. Often it forms a loop at the end, but still progresses forward. So introduce some air as you're doing this as well. So basically you can't rush this, we've just got to go slowly, work with the contractions if you get any. There's some very weak contractions starting at the end there. It's a good sign. Just little by little we move on down. If you feel any resistance and it starts moving, then just stop for a minute, wait, and then move on. Most importantly, have a clear view at the end so that you can see whether or not it's doubling up and coming back on itself, because that's what you want to avoid. So you can imagine you're looking at the fluoro and probing backwards and forwards to flip it into the next loop. So as soon as there's a resistance, pull it a good 6 inches back and then move forward. Good. So we're probably far enough down. Okay, David?
Yes, sir.
As soon as you meet resistance, then just use your guide wire to push the end of the scope out slowly.
Okay.
So just move your body back as you're moving the guide wire in. That's good. And remember, once you're coming back, you can't put loops in the duodenum, so keep feeding in as you're coming back. Keep feeding in. Feed, feed, feed as you come out. Yeah. Let your scope come back. That's it. Yeah. Come out. Good. Feed, feed, feed until you're in the stomach. Once you're in the stomach, then it's a different game. Okay. Feed, feed. Still in the duodenum, right?
Yes.
Still feed, feed, feed. Because if there's that redundant loop, you have to feed a lot of extra guide wire as you're coming back out. As soon as you're in the... Okay, now we're coming back into the stomach. Now what's next critical is that we keep the guide wire straight in the stomach. We don't want to leave any loops. So turn towards the left and lay it down on the rugae. Look up a little bit so you see what you're doing. That's it. Lay it down. Keep on the greater curvature. Keep feeding in. Good. Keep it nice and straight. Beautiful. Nice and straight. Keep feeding. Perfect. Look at that position. Take a picture of that so that for your records. See how it's nice and straight. Okay, now one for one as you're coming back up the esophagus. Ask your assistant to grab the wire as you come out through the nose. One for one. One for one.
Can we do it one by one?
Yeah. Sucking all that juice out of the esophagus. Come. So now we're ready to pass the feeding tube over the guide wire.
I mean, that's just giving you an idea where to hold it. This is all flushed, or? So this jejunal tube has a black mark, and it's positioned to about here. You can see that black mark.
Yep. And what about the end of it? Is it? No, put it on. You've got to push it together now. Okay. So it's held firmly in position, and that means that the end of the J tube just sticks out in the end of the G. So can you just show that, David? Right at the end, you see? So there's just a little floppy bit coming out of the G, and that allows it to pass down the nose quite nicely. So the next part is critical, that we keep the guide wire as taut as possible. So we've fed the feeding tube over the guide wire, and the end of the guide wire must be tethered by our assistant onto a firm surface, as shown here, so that we've got a taut process, and then we can simply slip the whole feeding tube system over the guide wire through the esophagus, stomach, and then down through the stomach into the duodenum. So that's the thicker G tube going over, and the whole thing is sliding down. Now we don't put it all the way in, and we stop there. And then what's very important is we now place the endoscope through the other nair and check its position in the stomach and make sure there's no loop. So just relax everything now. We've got two choices. We can either go through the alternative nair, or we can go through the bite block, whichever is easier. What are you going to use, David?
Start seeing the tube there.
Follow the tube. Okay, so we go through the esophagus and make sure that the trajectory is straight towards the pylorus. So just follow that round, David. Don't go as far as the antrum. Okay, now we know that we're straight and we don't have a coil. We can then position the J tube through the G. So here we've got the washer. So we pull the washer back so that we release the J tube, and we pull it all the way back along here. Okay, and then we're keeping the guide wire taut. We then slowly advance the J tube through the G tube, as is shown here. Just take your hand out of the way to show what you're doing. Okay, feed it in again. Take your hand out of the way. Feed. And so basically it runs all the way through the esophagus, the stomach, into the duodenum, and then along the guide wire into position in the mid to distal jejunum. And David at the same time is looking at the endoscope to make sure that it doesn't buckle back.
Give me this end.
Okay, so the G tube is in good position, it's straight, there are no kinks or anything, and as you can see it goes through the pylorus nicely there, so we're in good position to make the final connection with the J port. And so just keeping the guide wire taut, we just move in the final part of the J through until the washer reaches the end there, and click it on, and that's in perfect position. So now we're able to take the guide wire up, flush the system, make sure that everything works. Is it flush?
It's flush.
Flushes easily. Beautiful. Okay, so we're good to go. Well done. So now all we need to do is place the bridle.
I'm going to withdraw the scope.
Yeah, you can take the scope. And now do a wiggle as you come out, David. You know how to do that. Usually because the G port is 16 French, it's stiff, so it doesn't come back, which is nice. And but you try and unstick it from the scope as you pull back, jiggling backwards and forwards. Okay. So we get the famous bridle. Okay, so those are the two pieces of probes with the magnets at the end. Grease them up well.
Some space here.
Like that? This is the last part of the test, honey.
Okay, so there it is on one on either side there. Okay. And then just advance it towards the back, and suddenly you feel a click as they go together. And there it comes. Through. Perfect. Often I add a little bit of lube to the tape as well, just to make it soft. But bleeding is actually not usually a problem. So this is the clip that we put, and it's specific for this tube, so it's a 16 French, and it just flushes over and clips onto that outer G tube. And then we snag one of those tapes inside the clip. Like that, great. Just show it click together. That's it. And we leave a little bit of leeway, perhaps a couple of inches, and don't put it too tight. And then we're good to go. So we just do a good surgical knot, and we're good to go. Tight.
I can get another one out.
Take a bow. Thank you very much.
Okay.
To the members of our team, thank you, Laura, and thank you,
Nikki.
Nikki, who joined us.